but you could be ovulating and you could conceive. It's called a change in life, baby.
And I'm not looking for a change in life, Pete. So let me be clear. Hello, and welcome to the Twin Sister Docs podcast. I am Dr. Lynda Wardlaw, and I am Dr. Lynda McDonald, and together we are the Twin Sister Docs. Today, we have a guest with us today, Dr. Lynda Thomas-Mabine. Dr. Lynda, I will let you introduce yourself.
Thank you. Hi, everyone. I am Lynda Thomas-Mabine, and thank you guys for inviting me. It is a pleasure to be here. I'm a board-certified OB-GYN in practice for over 30 years plus on staff at Chestnut Hill Temple University Hospital located in Germantown section of Philadelphia. I've been practicing for a very long time, and menopause and fibroids is right up my alley to talk about today.
Yes. So thank you for joining us. We love to have experts on the show to help us drive home very important points for our listeners. So today, as Dr. Thomas-Mabine has just said, we're going to talk about two very important topics. Menopause, that change of life. And then if we have time, we'll talk about fibroids. So there we'll have it. So Dr. Mabine, if you would be so kind to just describe to us, when people talk about menopause, what exactly do we mean when we say menopause?
So all of us, including myself, who has been blessed to get older, will transition. All women on planet Earth will transition to that time in their lives where they no longer are having cycles, and the cycle has stopped for 12 months. The mean age for menopause is about 51, 52, meaning half of all women will have completed that time of reproduction when they no longer are ovulating, no longer having periods. So after that 12 months of no cycles around that age period, you are considered postmenopausal. Now, I don't like the word postmenopausal because you're menopausal for the rest of your life. So if we've been blessed to get older, we're going to spend a third, a quarter, maybe a half of our lives in that time period. We're no longer producing estrogen, progesterone, and testosterone. And many women begin to experience the hot flashes, the night sweats, the insomnia, the vaginal dryness, the decreased libido, the mood swings. All that is all part of that transition. And for some women, it lasts forever, ever. Not every woman goes through it forever and ever, but many of us will be menopausal forever. And therefore, some of us will have those symptoms for a long time.
How, as we start to get older, I'm dating myself. I'm in my 50s. How do we know?
Okay.
How do we know that we're going through menopause? And you described some of the symptoms, but sometimes it takes a while for us to figure out, could this be menopause? Could this not be menopause? So at what point should we really start to be concerned that, hey, I might be going through this big life change?
So what I love is there's so much social media discussion about menopause. I love that the information is in the public sphere. So we all are going to get older. When we begin to experience that skip cycle, that perimenopausal time, which can happen anytime after 40, we'll have skip cycles, maybe up and down hormonal levels and mood swings. We may not be ovulating on a regular basis, but if you're transitioning 40 to 51, that perimenopausal time frame, you may be experiencing some hot flashes, some night sweats, some mood swings, some weight gain, joint pain, depression. All of that is part of that transition because every cell in our body is estrogen receptive.
Okay.
And
so how do we determine if we are truly in menopause or not? Because a lot of the symptoms that you have just described could be a part of other disease processes. So how do we determine, are there any labs to say, hey, this is definitely menopause that you're going through?
So you should see your doctor, whether it's your family doctor, whether it's your gynecologist, your internist. You want to see your doctor to determine, are my symptoms related to something else? am I menopausal? And there's some very basic labs we can do. There's a follicular stimulating hormone, estradiol levels, and we should also check your thyroid levels as well. Many of us, as we transition to being blessed to get older, are pre-diabetic. So I like to include in that spectrum of labs an A1C just to make sure we're not missing anything. And that's kind of the basic kind of lab you want to do. Some doctors will stretch out and do a lipid panel because if a patient is menopausal, we want to make sure they don't have any cardiovascular disease or thyroid disorder to explain the symptoms that they're having. Sometimes it could be just depression, but depression could be aggravated by the change in hormones as well.
So, as Dr. Wardlaw and I often say on our podcast, what's good for the goose is not good for the gander. So, don't go by what your girlfriend did, what happened with your mother, what happened with your colleague. You have to go speak to your doctor because your doctor knows your history, your doctor understands you. So again, please go visit your doctor. And just as a reminder, this is general information. So we're not speaking directly to your specific cases. So again, another reason to talk directly to your doctor. With that, Dr. Mabine, another question that many people have that arise, I see this question arise all the time. Okay, so your tests come back and the test is saying one thing, but you're feeling another way. How do you address those patients, Dr. Mabine?
So especially women who are perimenopausal. I mean, they're coming to me and they're saying, hey, I want my hormonal labs checked. If you're perimenopausal, I think it's a good idea to check them. But if you're 60 and you're postmenopausal, it's kind of academic. Do we really need to check your hormonal levels if you're 16 and you haven't had a period for 10 years? I know you're menopausal. So you treat the symptoms. You could be perimenopausal, having hot flashes, night sweats, skip cycles, mood swings, decreased libido, and sometimes those women's labs may not reflect their symptoms. You want to treat the symptoms. So a low-dose birth control pill for women who are not quite menopausal may work as long as they have consulted their physician, they know that they don't have underlying cardiovascular disease or blood clots or existing cancers, that hormonal replacement therapy is contraindicated. So it's important to have that conversation with your doctor to make sure your risk factors have been checked off. And there's some very low dose estrogen birth control pills at 10 micrograms of estrogen, which is really, really low, that will help you through that transitionary time. And then somewhere around 48, 50, go off them as long as you're not having any issues to find, do I really need to be on a low dose birth control pill? Or can I now transition to something that is safer because I'm now menopausal?
Now, to follow that up, so many patients will come in and they are not perimenopausal or menopausal, but they're having a variety of symptoms, which we know can be a part of other disease processes as well. But many people want to come in and get their hormones checked at 29, 25, 30 years old, having a cycle every 28 days. How do we address those patients, Dr. Mabine?
So a thyroid stimulating hormone would be something I want to do on that patient. There is something called premature ovarian insufficiency or premature ovarian failure. So in those patients, if they are having no cycles or skip cycles, you want to make sure they're not menopausal or prematurely menopausal, and checking an FSH kind of gives you data to help alleviate their anxiety and to figure out what's going on.
Okay, and so for the younger patients who no skip cycles, everything is regular cycle-wise. However, they have these symptoms, and then you are convinced that this is their hormones.
I get that question all the time. It is quite challenging. The blessing of being in practice for 30 plus, almost 40 years, is you have relationships with your patients. They trust you. So trying to have that dialogue about, hey, based on your symptomatology, this is what we can do to find out what's going on with you. And sometimes it's just a matter of getting the data to reassure them. We're going to check your labs. I'm sure you're not menopausal, but you could be surprised. Or let's find out if we don't have hypothyroidism or hyperthyroidism to help alleviate them. But they do come in often because this is a huge social media discussion. Check your hormones.
Yes.
And so for young women, checking a thyroid, doing an A1C, doing a lipid panel, and just holistically talking about what's best for your lifestyle to help alleviate some of the symptoms that you have. And that may be open another discussion about taking care of yourself holistically.
And as we always say, who is they? Know your source. So when we talk about social media, you need to be aware of where the information is coming from. So any information that you are receiving, please take it into your physician so that we can go over it with you and decide what is the next best step for you. So again, you have to have that conversation with your physician that you should hopefully have a trusted relationship with so that you all can make the proper decisions moving forward. Now, Dr. Mabine, estrogen replacement or hormonal replacement therapy. We know that there are some cases that that's not appropriate for, and even some age restrictions that that's not appropriate for. Can you talk a little bit about that, Dr. Mabine?
Yeah, so hormonal replacement therapy is not for everybody. So you may remember over 20 years ago was the Women's International Study
Yes.
that was done. And we as physicians were not really educated on menopausal management through med school. The curriculums are changing now because when that WHI study came out, it really put a damper on estrogen and talked about all the ills of hormonal therapy. So for years, women were deprived of the opportunity to get hormonal replacement therapy. We now know that that WHI study has a lot of fault in it. And there are additional studies that have been looked at to show there's a lot of safety profiles in hormone replacement therapy and preventing hot flashes, night sweats, osteoporosis, brain fog. So there's huge benefits to it and helping with libido. So we need to really have that discussion with our patients about, are you a candidate for HRT? And you mentioned about age. So is it too late to start? If you're 65 and you are suffering from hot flashes, they're back again, night sweats, mood swings, decreased libido, have a shared decision making about the risks. Are you concerned that the patient may have some underlying cardiovascular issues? Then see your doctor, get cleared by your family doctor, your cardiologist, and make sure there is no contraindication to its use. Make sure you've had your mammograms to make sure there's no underlying breast cancer. And you're not a smoker. That's a huge risk factor for patients on hormonal replacement therapy. Most hormonal replacement therapies that I recommend, and most docs who are part of this new culture of replacing patients back on HRT, are using transdermals. The Women's International Study was done with one medication called Prempro. And Prempro was made from pregnant mare's urine. It was a lot of pro-inflammatory issues with that. And now we know subsequent studies that transdermal hormonal therapy is much safer. So many of my patients are on transdermal and maybe supplemented with the progesterone if they still have an intact uterus.
And when you say transdermal, you're talking about a patch that goes on the skin.
Yes,
Just to be clear,
yes.
we're talking about a patch that goes on the skin. So a couple key points that you have pointed out, that research is what drives medicine, but some research studies we may find out later on may be a little bit flawed, but research leads to more research. And when we know better, we do better. So there is life after menopause.
Oh, definitely. And you want to treat the symptoms. We should not suffer because we're getting older. We should not want to be with our partner because of the decreased libido and the vaginal dryness or the mood swings that you start yelling at someone all of a sudden. You're like, what happened here?
Yes.
Because it does affect your brain. We think of menopause as an estrogen ovarian event. It's actually a brain event. So there are a lot of new drugs on the market that affects the thermoregulatory cycle in our brain without being on hormonal therapy. There's some really new drugs out. So if you had breast cancer, for example, or if you had a blood clot, you may be able to try some of these new drugs that is contraindicated for you if you couldn't go on hormone replacement therapy.
And for our listening audience, can you clarify when you say thermoregulation?
Okay, so You got a thermostat in your house, right? The heat goes up, the heat goes down. Well, there's areas in our brain that regulates our heating, our cooling. And so estradiol, which was the predominant hormone from the ovaries, impacts that area in our brain that makes us have hot flashes or makes us sweat when we're too hot and cool us off. So that thermostat in our brain, the thermoregulatory center in our brain, is impacted by either the lack of estrogen or too much estrogen.
So the body's working off of a feedback system. Everything is connected. Everything is connected.
No question.
And so, Dr. Mabine, you talked about the hormone replacement therapy, whether it's orally or through your mouth, or whether you put a patch on your skin. Are there some topicals that patients can use if they're having like vaginal dryness or having pain with intercourse or?
Yeah, so the transdermals could be a patch that's put on the skin. It could be a cream, and that cream could be a lotion. There's just some estrogen sprays, the estradiol spray. And then if your symptoms of vaginal dryness, there's estrogen vaginal creams that can be used. There's estrogen pills that could be used. There's an estrogen ring that actually can be inserted and left in like a diaphragm for 3 months at a time. The issue is a lot of these products, unfortunately, are not covered by health insurance. I have patients that say, oh, it's $100 for a supply. But for a lot of patients, like, I don't want to spend $100 and I have a prescription paying for something. You have to work with your doctor. Sometimes they have to do pre-authorizations. They have to find out what's on your formulary to find out what drug is good for you that it can be costly for you to be able to afford.
And you can help your doctor out too. You can call your insurance company and see what's on your formulary as well. You can also call your insurance company and say, my board certified physician is recommending this treatment. Can I receive this treatment? So you can advocate for yourself with the insurance company also. So, Dr. Mabine, we talked about the different treatments. So can we talk about other non-hormonal treatments like low-dose antidepressants and some herbal type of medications that are available?
I think we need to also think about lifestyle change, right? How we deal with stress, because that can also add to the hot flashes and the insomnia. So in addition to trying to manage the estrogen depletion part of what's going on, you need to make sure that you're exercising, that you're eating well, that you are reducing your stress as best as possible. And then the use of SSRIs, which are the antidepressants. There are women who cannot take hormone replacement therapy, do not tolerate any of the alternative options. And sometimes depression is their biggest symptom. Mood swings are the biggest symptom. So we know that the brain is stimulated by either the lack of or excessive amount of estradiol. So going on an antidepressant works really well for even PMDD, which is premenstrual dysphoric disorder, which is that PMS that we talk about.
Yes.
When they do really well with just low dose to help with the mood swings as an alternative. Yeah.
So, listen, it's a change that all biological women are going to go through and experience. It's inevitable. Listen,
If you live long
if you live long enough,
Yes,
if you
amen.
live long enough, if you live long enough. But we also have to remind people that when you're going through this transition, you still are able to have a baby. Dr. Mabine.
Oh,
Are you
yes.
fine?
Yes, thank you so much for bringing that up. So perimenopause, meaning that your hormones are doing this. And when it peaks, you could be ovulating. So a lot of women, oh, I'm 45, I can't get pregnant, my cycle's skipping. My oldest prenatal was 52. Yes, 52. So you can, I mean, you're not ovulating at the same quality, but you could be ovulating and you could conceive. It's called a change in life, baby.
Surprise, surprise. And I'm not looking for a change in life, baby. So let me be clear. Dr. Mabine. So don't walk into a surprise, okay?
So make sure you're using some protection. It's real important. Unless you are completely menopausal, it's been 12 months, your doctors confirm that you are menopausal and you're in that 50th like window, please use something to protect it. If baby is not what you want, and if you want a child, that's a different story. But
Sure.
If pregnancy is not your goal, please use some
Yes.
protection definitely.
12 months, 366 days. If
Plus one, right?
plus one, if there is any possibility that you can get pregnant, you need to protect yourself. You don't want to be the one that says, well, I didn't think it could happen to me, because it could happen to any of us. And so with that, Dr. Mabine, so thank you. So some key points that we would like to remind the viewers of. One, perimenopause, menopause is to change your life. It is going to happen if we get to that age. Two, we don't have to suffer.
Yeah.
So please talk to your doctor so you can discuss your symptoms, you can get the appropriate evaluation and get the appropriate treatment that you need. Three, hormone replacement therapy is appropriate for some, but not appropriate for all. So again, please have the conversation with your physician. Yes. Yes. We do not have to suffer. We do not have to suffer as women.
And holistically, you want to look at your whole change of life as a evolution to wellness. So exercise, eating well, knowing your numbers, seeing your family doctor, getting your blood pressure checked. Cardiovascular disease is the number one killer of all of us.
Yes.
So even though we're menopausal, we still have to take care of this heart. So the holistic approach is really important.
Well, thank you, Dr. Mabine. So now we're going to transition to topic number 2.
Oh, okay. My favorite, fibroids.
Yes, exactly. We're going to talk about fibroids. So, Dr. Mabine, can you please start off by explaining what fibroids are?
Happy to do so. So uterine fibroids are actually these buds that grow off. If my fist is a uterus, these little buds grow off of the uterus, and they're like gristle-like buds of the uterus. So think of a potato as it gets older. It grows little buds. It is stimulated by the female hormone estrogen. So fibroids, actually these little growths on your uterus, usually begin around 30 or 40. They are 99% benign. And 1 in 8 women in this world will have them. They're very, very common. They affect up to 80% of African American women, about 70% of other women, European and Asian women. Very, very common. Stimulated by the female hormone estrogen. They are 99% benign, as I said, but they can cause about 25% of women will have symptoms of irregular bleeding, pelvic pain, pressure symptoms, and occasionally can cause some fertility issues.
How are uterine fibroids diagnosed? Yes.
Many women don't know they have them. You come to your GYN's office or your family doctor's office, does a pelvic exam, and they feel an enlarged growth in the pelvis. The best way to confirm that, because a lot of things could be a pelvic mass, it could be uterine, it could be ovarian, it could be bladder, it could be colon, you get a pelvic ultrasound. But if usually it feels like a fibroid, you're probably a spot on. If you're totally asymptomatic, meaning you don't have pain, you don't have bleeding, you had no idea that you had these, the ultrasound is the way to go. And once the ultrasound confirms that you have these fibroids, which I said 80% of all women have them, the question is, what do you need to do about them? And most of the time, nothing. They are 99% benign. So the treatment option is based on your symptoms. Are you having irregular bleeding? Are you having pelvic pain? Are you having a fertility issue? And if you're having symptoms, let's tailor your treatment to the symptoms. Sometimes a low-dose birth control pill can control the symptoms. Sometimes an IUD, which is my favorite contraceptive treatment for pregnancy prevention and for bleeding control. There's several IUDs on the market. So if your bleeding is the issue, we can easily insert that IUD in an office procedure, and it works 95% of the time in improving your symptoms. And in some women, it helps to improve symptoms to whenever they change into menopause. And for others, they may need to have surgical interventions. That could be a myomectomy, which is an operation to remove the fibroids and reconstruct the uterus, which is ideal and reserved for people trying to have a baby. And then there's uterine artery embolization, which is a procedure used to cut off the blood supply to the fibroid uterus and the fibroid shrinks.
Okay. And so I will say that gone are the days where if you have a fibroid uterus, you have to get a hysterectomy. Yes. Now, if you have tried other treatment modalities and you're still having issues with abnormal bleeding, heavy bleeding, your blood count is dropping down to 4 or 5, then, you'll obviously have a conversation with the physician. But my point here is that the days of going in and having a hysterectomy as the first option for treatment of uterine fibroids, that is not the case anymore.
I would definitely agree. It is a surgery to remove the uterus is a last resort procedure. I am a minimally invasive robotic surgeon. So I do myomectomies, I do hysterectomies. And if you exhausted all conservative options and you're still asymptomatic, it could be the right choice for you. And then you need to have that discussion with your doctor about, do I do it minimally invasively? That means a small laparoscope into the belly button and remove the uterus that way. Should I take my ovaries out? And in young women, you should retain your ovaries unless there's a family history of ovarian cancer or some other reason why the ovaries need to be removed. The hysterectomy is the last resort. It is the only thing that 100% will get rid of all your symptoms, and the only way to 100% determine if you're in that 99% benign category.
Okay. And then, so after, well, we talked about menopause, once you go into menopause, how does that affect the fibroids?
So fibroids are stimulated by estrogen. So guess what? I'm menopausal. And if you can wait it out and you've done all these conservative things, once you're menopausal, estrogen levels go down.
Mm-hmm.
Your fibroids are supposed to stop growing. They definitely should not increase. So if you're menopausal and you're definitely having fibroid symptoms, that is a concern that you may be in that 1%. So you want to see your doctor, say, hey, I'm having increase in abdominal girth, I'm having pain, I'm having postmenopausal bleeding. There's something going on here and that needs to be addressed.
Right. And postmenopausal bleeding is a something that definitely needs to be addressed. So if you've not had a period of 366 days, you're menopausal, and then you start to have vaginal bleeding, you absolutely need to have a conversation with your doctor. Yes. And as you mentioned, Dr. Mabine, you said 80% of African American women have fibroids. Well, I indeed was one of those women. And Dr. Mabine was my physician. And as Dr. Mabine explained, pretty much everything she said has happened to me. I did not know I had fibroids. I went in for my routine exam, and Dr. Mabine said, I feel fibroids. Did you know you have fibroids? I said, no. She said, are you having symptoms? I said, no. She said, we just watch. Well, lo and behold, once she told me I had fibroids, maybe about 6 months later, I started to develop significant heavy bleeding, irregular periods. Sometimes the period would be on for 3 weeks at a time. And, just couldn't get through the day, meaning changing outfits. So it was really affecting my quality of life. And when I went in and talked to Dr. Mabine, she went over my options with me. And again, based on my history, my exam, she explained to me my options. And she did say, listen, based on your age, you could potentially wait it out. I said, absolutely not. I cannot live like this. So what are other options? And based on the options that she offered to me, I decided on to get in the uterine artery embolization. And can I tell you, life changed. Life changing since I had uterine artery embolization. I would have Dr. Mabine explain to you how it works. Yes, 80% of African American women could experience it. You do not have to be miserable. There are options, and I am one of those patients who definitely experienced the fibroids, the irregular bleeding, but I also had the procedure to relieve that.
I am thrilled that it worked for you.
Yes.
And it works for most women. So it's done by an interventional radiologist. She's like, what is that? That's a x-ray doctor, a radiologist. Interventional radiologist can take a catheter through the main artery in your arm called the radial artery and trace it down to the uterus. And what they do is under x-ray guidance, they put these little pellets in. It cuts the blood supply off to the fibroids and the fibroids shrink. And most women have significant, like you, resolution of the symptoms. It's outpatient. You may stay overnight or
Yes.
go home that same day, but you're back to routine in 2 weeks.
Yes. And I will say, after I had the procedure done, I felt like those fibroids were angry because I was in pain. I was in significant pain, which they warned me about for about a good 48 hours. And then the pain started to subside, and I was out of commission for about a good 2 weeks. I was exhausted. I was tired. They also warned me about that. However, once I got past that point, can I just tell you, life has been so much better, so much better. So I want to personally thank the interventional radiologist who did the procedure, Dr. Emily Cuthbertson at Temple. She saved my life.
Yeah,
And of course, Dr. Mabine.
it works tremendously well for a lot of women. But if you're not getting response, if you didn't have the wonderful response that most women have, and like you had, Dr. McDonald, then you need to further investigate, find out what's going on.
So every time I see Dr. Mabine, I give her a big hug. Tell her, listen, you changed my life. So with that being said, Dr. Mabine, thank you so much for joining us, for giving us expert information, to let us know that menopause is, we do not have to suffer. Okay, we do not have to suffer from uterine fibroids.
Do not.
Yes.
Well, thank you. It's been my pleasure to be here with both of you.
Thank you, Dr. Mabine.
Thank you.
Thank you for tuning in. We'll see you on our next episode.